Hi everybody, and thank you for joining me in this new short video presentation regarding the ECG exercise number 7. I hope you will enjoy this video and join me in my future video presentations. The ECG belongs to a 48-year-old man presenting with frequent PVCs for catheter ablation. In these patients, the PVCs have a left bundle branch block morphology with superior axis and a late precordial transition. The echocardiography and cardiac MRI were completely normal. So, where is the origin of the PVC? Of course, because the PVCs have superior axis, we can exclude the outflow tract as the possible site of origin. Then we have other possible structures like septal papillary muscle, parahisian region, septal band, and moderator band. In these cases, usually the QRS is narrower and we have either an inferior axis, or in some cases like moderator band PVC, usually we have discordance in 2 and 3. It means we have a positive 2 and negative 3 if we don't have an inferior axis. Compared to these structures, we have anterior papillary muscle. Usually anterior papillary muscle in right ventricle shows a superior axis and the QRS is wider, the transition is later, and we see notching of the QRS complex, especially in precordial leads. Now we go back and look at the ECG in our patient. Our patient showed the typical findings of PVCs originating from the anterior papillary muscle in the right ventricle. Ventricular arrhythmias from the right ventricular papillary muscle are much less frequent than arrhythmias from the left ventricle. In general, such arrhythmias have a left bundle branch block morphology and the QS pattern in lead V1. Among these arrhythmias, the focus in the septal papillary muscle resembles the source in the RV outflow tract on ECG, especially when the focus is on the conus papillary muscle. Then the QRS is positive from lead 1 to 3. The anterior papillary muscle in the right ventricle have a wider QRS complex with a notched appearance in the precordial, and anterior RV papillary muscle usually have a superior axis with a late R wave transition as compared with septal papillary muscle arrhythmias, which often have an inferior axis and an earlier RV transition. This figure shows the successful signal recorded on catheter ablation on the earliest point on the anterior papillary muscle. Putting together here, we see the fluoroscopy and 3D mapping in RAO and LAO projections showing earliest point and successful ablation site, and also the best pace mapping in this procedure. In conclusion, this was a typical ECG presentation of a patient with idiopathic PVC originating from the anterior papillary muscle of the right ventricle. I hope you enjoyed this video, and I would like to invite you to join me in my future video presentations.